Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins sleep surgeon Kevin Moats will be speaking about what's new in the surgical treatment of obstructive sleep apnea. Before we get started, we'd like to provide some user tips so that you're comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click Send. Your questions will be seen by others watching this presentation, so please note, if you don't want your name attached to your question, please check Send anonymously. We will do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Moats to begin our presentation.
Good afternoon, everybody. Thank you all for joining and being part of this webinar. I'm Kevin Moats. I am the Chief of the Division of Sleep Surgery in the Department of Otolaryngology here at Johns Hopkins University School of Medicine. I specialize in the treatment of obstructive sleep apnea, particularly for patients who are struggling with CPAP. So the focus of my talk today, or to this webinar, will be really obstructive sleep apnea and really treatment options for patients who are struggling with CPAP. I don't have any conflicts of interest or any other financial disclosures related to this talk. So briefly for today, what we will do is we'll first review the clinical definition of what exactly obstructive sleep apnea is, review the consequences of untreated sleep apnea and really why it is a focus of healthcare and why it's important to your healthcare if you do have it. And then finally, we'll discuss treatment strategies for the management of OSA with really a focus on non-CPAP alternatives for treatment. So what is obstructive sleep apnea? Obstructive sleep apnea is really characterized by repeated episodes of upper airway collapse during sleep that limits airflow despite the body trying to breathe, so that there is an effort to breathe. These episodes of upper airway collapse are associated with a reduction in oxygen saturation or with a patient sort of arousing from sleep. So throughout the course of the night, a patient with obstructive sleep apnea, their upper airway will become relaxed. It'll eventually sort of collapse, preventing airflow, and then it leads to their oxygen falling or their body eventually saying, hey, wake up. And so normal breathing throughout the night, there really isn't any limitation of airflow. But with sleep apnea, we see these repeated episodes of limitation. So essentially, when we go to sleep, what happens is we lose muscle tone in our upper airway, and these tissues collapse on themselves. And there's really three primary reasons for this. So pretty much every patient with sleep apnea doesn't obstruct when they're awake. And so this is really a disorder at night or during sleep that is predicated on a certain amount of reduced muscle tone in the upper airway or the throat. This reduced muscle tone is what is driving the airway to collapse. Secondarily, some patients have certain anatomy that predisposes them to a more narrow or compromised airway. So if the airway is narrow to begin with because of a small jaw or a large tongue, and they lose a little bit of muscle tone, that airway will collapse at night and block airflow. And finally, the third real driver is obesity or excessive weight, which really makes the airway heavier and more collapsed at night. And so while maybe at a normal body weight, there's enough muscle tone to keep the airway nice and open, as a patient may gain weight, the airway becomes heavier and that sort of intrinsic muscle tone is no longer enough to keep the airway open. And so how do we think about obstructive sleep apnea? Well, really, it's almost kind of crude. We think about how many events or breathing events a patient has per hour. And we calculate this into something called the apnea hypopnea index, or the AHI. And this is really where when a patient says, oh, I have severe sleep apnea, it's really determined upon this AHI. And what it is, it's the average number of obstructive breathing events per night, or average number of times a patient has a pause in their breathing. We all do this to some degree. And so normal is really having an AHI less than 5. Mild sleep apnea is about 5 to 15 events an hour. Moderate is 15 to 30. And severe OSA is when a patient's having more than 30 breathing events on average per hour. And so, a lot of people might say, well, why do I really even care about sleep apnea? Why do I need to treat this? Why do I need to use a CPAP? Why do I have to do this? And really, it's twofold. So what we know about obstructive sleep apnea is that there's an increased risk of cardiometabolic disease, and that's a big word. And so cardiometabolic disease really means anything wrong with our metabolism, our glucose regulation, as well as our cardiovascular system. And so what we know about sleep apnea, and particularly untreated sleep apnea, is that these patients are at increased risk for things like stroke, heart attack, atrial fibrillation, which is a funny heart rhythm. Oftentimes, patients need to be on a blood thinner for that. Heart failure, high blood pressure, diabetes, and in some cases, OSA is linked to premature death or just not living as long as you otherwise would. And so, because of all these factors, we feel very strongly about treating this. The other really big implication or need to treat sleep apnea is because it leads to poor sleep quality and daytime sleepiness. This is hallmarked by patients sort of dozing off frequently throughout the day, waking up not feeling refreshed. And this can have pretty significant impacts on patients and safety even. So there's higher rates of motor vehicle accidents, there's reduced productivity at work, higher rates of depression, and lower quality of life. And so what we know about both of these factors is really as that AHI, or that apnea hypopnea index, increases, so does our risk for some of these sequelae or bad outcomes related to sleep apnea. Now, not everybody with sleep apnea is going to be at risk for these. So patients with mild sleep apnea, we really don't see a lot of risk to it. It's really not until sleep apnea becomes moderate or in the severe range that we start to see these increased risks of stroke, heart attack, AFib. But patients with mild sleep apnea certainly can have daytime sleepiness. And so from that standpoint, we would still treat mild sleep apnea. Now, I'm pretty sure everybody's heard how we treat sleep apnea. One of the primary treatment modalities is something called continuous positive airway pressure, or CPAP. This is really the gold standard treatment for obstructive sleep apnea. Basically, what it is, it's positive pressure that is delivered to the airway with a little mask that either sits over or under the nose, sometimes over the nose and mouth. And it's close to 100% effective at treating sleep apnea from a mechanistic standpoint. So really, it just blows the airway open and holds it there and prevents it from collapsing. It's basically a pneumatic splint, and very, very effective. I'm a surgeon. I do a lot of surgery for patients with sleep apnea. And I'm always frankly honest, I can't beat a CPAP in terms of efficacy. And it's really the best option if it can be worn and tolerated. Unfortunately, despite it being such a great treatment, compliance with CPAP is pretty low, with patients having non-adherence rates of almost up to 50% at the 1 to 3 year mark after a diagnosis. And so basically 1 in 3 or 1 in 2 patients who are given a CPAP because they need that treatment for their sleep apnea can't use it, can't tolerate it, or stop using it. And so that really necessitates the need for alternative non-CPAP treatments for sleep apnea. And so with that in mind, there are a host of alternatives to CPAP that can be utilized to help treat patients with obstructive sleep apnea. And I typically break these down into two groups. So there's a host of non-surgical treatments that can be utilized for obstructive sleep apnea, as well as surgical treatments. In the non-surgical realm, we think about things like positional therapy, which is basically an intervention just to try to help a patient maintain side sleep or not sleep on their back, where we tend to see sleep apnea be worse. Oral appliance therapy, that's a dental device that's used to treat sleep apnea. And finally, weight loss. These can be all non-surgical approaches that help sort of reduce the severity or treat completely the sleep apnea. Now, on the other side of the coin, there's surgical options for the treatment of sleep apnea. And these are broad, and they can range from anything from surgery on the soft palate to reconstruct or reduce some of the tissue size, to surgery on the tongue, or surgery to really reposition the bones of the face and pull them forward to provide an expansion of the airway. And to finally, more neurostimulatory therapies such as hypoglossal nerve stimulation. These can all be utilized to help a patient find effective treatment for their sleep apnea. But you can see here that really the efficacy of these treatments is pretty wide ranging, with success rates being anywhere from 17% to 92%. Really, treatment options like these surgical treatments and non-CPAP treatments are somewhere between 50 to 70% rates of success. Some options like maxillomandibular advancement or moving the bones of the face forward is very, very effective, but it leaves something to be desired, and not a lot of patients want to undergo that. And so you're kind of stuck with treatments that are pretty good, but they're not as good as CPAP. And so I think that's really one of the take-home points for patients to understand, that if a patient is using CPAP well, alternatives are usually not advisable, as it's unlikely that a surgery will achieve the results that are somewhat consistent with that of CPAP. Now, that's not to say you can't explore alternatives if you are using CPAP. You just have to know that some of the alternatives to CPAP may not do as good of a job as CPAP. But quality of life really matters, and that's what can motivate patients to explore alternatives to CPAP. It's just, as I sort of always tell my patients, it's really, really, really important that you as the patient is as informed as you can be on the likelihood of success, the risks of the particular intervention, and really, what they might be trading. And so if CPAP is usable, but it's just super cumbersome, you get tangled in the hose, we could think about other things, but this might be a good treatment, but it might not be quite as good as your CPAP, and you're kind of left with weighing the balance scales of, would I rather use something that's a little bit unencumbering, or stick with the CPAP because it's maybe more effective. The other take-home point is that if a patient has moderate or severe OSA, they really, really, really need to find a treatment approach that works. And for patients that are intolerant of CPAP with this moderate or severe sleep apnea diagnosis, we really should be considering alternatives that we can use to find successful treatment, because we want to mitigate those risks. Okay. So now really, this is sort of getting into the nuts and bolts of what I do as a surgeon and sort of a sleep medicine expert and otolaryngologist, is really the treatment of the CPAP intolerant patient. And so what does that treatment look like? And so how do we really walk through this process? So if a patient shows up in my office and they have this diagnosis of moderate severe sleep apnea and they've tried CPAP and it's not working, what can we do? Well, the first thing we always discuss is really a retrial of CPAP versus consideration of some of the non-CPAP treatment modalities. It's never wrong to try CPAP again. It's really low risk. It's essentially just putting something on your face. Oftentimes what I find is a patient may have tried it 15 years ago with an interface that, isn't ideal. They may be in a different phase of their life. They're no longer working. They're retired now. And sometimes it works. And so it's never wrong to retry it. Now, if it doesn't work, it doesn't work. We move on, or we work concurrently. So they try CPAP while we start doing a workup for non-CPAP alternatives. Another really, really, really important point for treatment of the CPAP intolerant patient is weight loss. And not every patient with sleep apnea is overweight or obese, but it is very comorbid with sleep apnea, and it definitely makes sleep apnea worse. So if we can work towards a little bit of weight loss, it's going to reduce the severity of the OSA, and it actually will enhance the outcomes of other non-CPAP alternatives. So it's really part of a multimodal treatment approach for sleep apnea. And finally, again, for those patients where the CPAP truly fails, we have to start thinking about the alternatives and how can we guide that? How can we find the right either singular or combination approach for getting a patient's sleep apnea treated? So what this really starts with is really an accurate characterization of their sleep apnea. A lot of patients, when they're first diagnosed because they're snoring, they get a home sleep study. It says, yep, you got it. They get a CPAP. They try it. It either works or it doesn't. But that home sleep study is really a screening tool. It's not giving us sort of the granular detail of what's happening at night. And so for a patient that's exploring potentially surgery or another non-CPAP alternative, a non-surgical approach, we really want to make sure we have a good sleep study. And what that is an in-laboratory polysomnograph. This is the in-lab sleep study, quote unquote. And it's really recommended because it gives us the clearest look at the severity of the sleep apnea and what's happening with each breathing event, as well as helping us understand the breathing patterns that are happening at night. It's not uncommon that maybe 5-10% of my patients that are coming to me because their CPAP, didn't work for them, actually has something called central sleep apnea. And surgery is unlikely to help that. And so we have to go down a different route. But it's really because we have this good characterization on the sleep study that we can discern that. And the second part of accurate characterization is something called a sleep endoscopy or a drug-induced sleep endoscopy. This is really for guiding surgical therapy, but it's a sedated exam where we assess how the upper airway is collapsing so that we can provide a more tailored treatment approach. Okay, so now that we have our good characterization, part 2 is really recognizing that, okay, we're moving away from CPAP. We know that all of our tools in our toolbox for treating sleep apnea aren't necessarily 100% effective. So we have to sort of put multiple things together. So we really need multimodal treatment and really sometimes multidisciplinary treatment to getting a patient's obstructive sleep apnea under control. And I'll go into this in a little bit, what exactly this looks like. But what I can just kind of allude to is that, the combination of a little bit of weight loss and a surgery, or a little bit of weight loss and a surgery, plus maybe a dental device, we can get the job done. And I think that's the most important thing, is that we're focused on a finish line. We want to get the sleep apnea controlled by putting multiple interventions together, ideally limiting how many we need, but recognizing that we're going to do this in a stepwise progression to get to our ultimate goal of successful OSA treatment. And finally, what are our goals? And so our defined goals of treatment are really twofold. Sleep apnea treatment doesn't have to be perfect. We don't have to take that AHI down to 0. We don't even necessarily have to take it down to normal. We really just want to see that reduction in the AHI come below 15, because that's really where the risk of sleep apnea starts to go away. And so, we have a little bit of wiggle room. And so that also brings to light, where does sleep apnea have to be treated? As I mentioned earlier, mild sleep apnea doesn't necessarily have to be treated. If a patient's kind of right on that border of mild to moderate, their AHI 16, it's like, well, should we really do a surgery? Or maybe, hey, let's try to get 10 pounds of weight off. That may push us into the mild range and we don't have to do anything. The second part of treatment is really trying to focus on improving sleep quality and reducing the daytime symptoms associated with sleep apnea, which are daytime sleepiness, dozing off, improved cognition, and all the sort of the things that go along with getting good quality sleep. Okay, so now that we kind of have a framework for how we approach this, what do our treatments look like? I'll first start by reviewing some of our non-surgical treatment options. The first one I'd like to highlight is oral appliance therapy, also known as mandibular advancement devices, OATs. These are dental devices that treat obstructive sleep apnea by holding the lower jaw in a more forward position. This expands the airway and prevents collapse. These can be custom-made devices that are used, and if they're going to be long-term, they should be custom-made by a dental professional. They are typically reserved for mild or moderate sleep apnea, but there's really no reason they can't have a good effect in some patients with severe sleep apnea, particularly if they're untreated, right? So if somebody's not using a CPAP, well, doing this may be better than doing nothing. These can be limited by cost and insurance coverage. A lot of times what I'll do is I'll have a patient trial a prefabricated device or a boil and bite just to see if they tolerate it, to see how well it works. Does it reduce their snoring? Are they sleeping better with it? And if those things are yes, then we send them to get a custom device from a dentist. Afterwards, we always want to get a sleep study to assess treatment effect. Make sure we're actually getting down to that below 15 number or into the normal range, making sure we're having a good outcome with this treatment. And that's true of most of our interventions. We're going to have to test after we do them to make sure we hit our goal. Positional therapy is another non-surgical treatment, as I alluded earlier. Sleeping in a non-supine position can treat some patients' sleep apnea. Some patients only have sleep apnea on their back, and that's really where the sleep study comes in as so important, because we can kind of see, oh, wow, when they're on their back, they're severe. When they're on their side, they have no sleep apnea. And so we can use positional aids such as bumpers or pillows or devices, biofeedback devices that a patient will actually wear to help train them to maintain non-supine sleep or maintain sleep on their side. Next is weight loss. And I talk about this a lot. I've already alluded to it, but weight loss is advised in any patient with OSA, whether they're on CPAP or not, who is overweight or obese. Weight gain is so highly correlated with the development of obstructive sleep apnea, and weight loss can really, really reduce OSA burden or eliminate OSA completely. We don't ever know how much weight a patient needs to lose to cure their sleep apnea, and so it's a little bit variable. And some patients lose and go to a normal body weight, and they do still have sleep apnea. So it's not foolproof, but it is always helpful. And really, it helps to alleviate a lot of other, comorbidities that come along with being overweight or obese. Recently, there's been a lot of emphasis and news about GLP-1 agonists, medications like, for example, Ozempic, Mounjaro. Trizepide was just published in the New England Journal as a treatment for obstructive sleep apnea. Now, these medications don't actually treat obstructive sleep apnea. They treat sleep apnea through weight loss. But they can be very good adjuvants for patients who have struggled to lose weight. And so it's great if we can use that as part of our treatment arsenal. And then finally, we get into the surgical treatment of obstructive sleep apnea. And I can really kind of break this down into sort of three different areas. So first, we have soft tissue surgery for obstructive sleep apnea. And really what this is surgery in the throat. This includes surgery to reduce the size of the tongue or reduce the tissue at the back of the tongue, remove things like the tonsils, reconstruct the soft palate, or even modify the epiglottis. Really what we're trying to do is reduce tissue volume and reconstruct some of the tissues so they're less prone to collapse. Surgical examples of this are uvulopalatal or some people would know it by a UPPP surgery, an expansion pharyngoplasty, tongue base reduction, glossectomies, which is kind of removing part of the tongue. These are tough recoveries, but they can be effective and they can help lead us towards that sort of goal of getting a patient adequately treated. Some of the downsides are these aren't necessarily, as I alluded earlier, 100% effective. And really, they only address one area of the airway. And so a lot of times patients with sleep apnea have collapse at both the soft palate as well as the back of the tongue. And so we have to be thinking about, well, how do we address the levels that are collapsing? The sleep endoscopy that I talked about earlier helps us, as does, and then, if we know it's just one level, we can address that. But a lot of times it's both, and we really have to be thinking about, well, how can we get the tongue and the soft palate out of the way? The next is really craniofacial surgery. And so this is surgery on the bony facial skeleton. And so changing the bony framework. Some patients have deficiencies in their maxilla or their sort of midface or in their jaw that really kind of push things backwards. And so surgeries to really pull those bony structures forward can be very, very effective treatment options. They're not usually that well sought after because they can be painful recoveries, and then they will change the appearance of a patient. But for younger patients that really don't like the way their jaw looks or have, profound deficiencies, these can be great treatments because they're going to be pretty durable in the treatment approach. And then finally, this gets in the final treatment modality is really neurostimulation. So stimulating nerves and muscles in the upper airway to really open up the airway as well as provide more muscle tone to the airway so that it doesn't collapse. And this is really where the field of sleep surgery and innovation has gone over the last 20 to 30 years, originally pioneered here at Johns Hopkins, hypoglossal nerve stimulation. So what that is, hypoglossal nerve stimulation, is a neurostimulation treatment to treat sleep apnea that stimulates the muscles of the tongue by stimulating the nerve to the tongue, or the hypoglossal nerve. This dilates the upper airway. Examples of this are the Inspire device as well as the Genio device. And these are implantable systems similar to a cardiac pacemaker or a sacral nerve stimulator that really stimulates specific nerves and muscles of the body or of the airway to prevent and treat sleep apnea. These surgeries are really intended for patients who are intolerant of CPAP. And it's important to know they too have variable success rates, anywhere from 60 to 80% success rate with these surgeries. And success is dependent on a patient's specific biometric profile. And so I harped on weight loss a little bit ago, but what we know with hypoglossal nerve stimulation is as a patient's body weight goes up, their success with hypoglossal nerve stimulation actually goes down. And so that's actually important because I could implant a patient with a hypoglossal nerve stimulation device today, and it works fantastic. But let's say they gain 60 or 70 pounds, it may stop working. And so this emphasis on weight is really important to how we deliver effective treatment. But overall, hypoglossal nerve stimulation is being increasingly utilized as a treatment option, and it's very well tolerated. And I think that's one of the biggest upsides compared to some of the other surgical approaches. And so, keeping all this in mind, what patients really are going for and what we're really trying to provide when we deliver treatment is multimodal care, combining two or more of the above treatments to achieve successful OSA care and treatment. Sometimes this is soft palate surgery plus an oral appliance, soft palate surgery and weight loss and a hypoglossal nerve stimulation device. Basically, doing what we need in a stepwise fashion to get a patient adequately treated, or as I will often say, well, let's get you across the finish line. Let's get you treated. We're going to look at this first, and then we may have to add this. But, it's really becomes a journey to treat your sleep apnea. Whereas when patients use a CPAP, they put it on, it works. It's much less of a journey. Now, when we get away from CPAP, we're kind of committing to this journey. Okay, so that's sort of my spiel on how we approach this. I think, I wanted to talk a little bit more about hypoglossal nerve stimulation for the treatment of OSA because it really is a hot button topic. There's a lot more of this in the news and a lot more advertising, and really talk about first who it's for. And so really this is indicated for patients with moderate to severe OSA with AHIs between 15 and 65. Now, there has been a recent expansion to AHIs up to 100. At this point, a lot of insurance carriers haven't adopted that yet, but likely will be. The other thing is you can't have central sleep apnea, or at least you can't have a high burden of central sleep apnea, and that's at less than 25% CSA I have written here. The next thing is body weight. So your BMI or your body mass index needs to be below a certain level. The original clinical trials were below 32, but it's anywhere between 32 and 35, depending on insurance carrier. Now, again, the FDA has now increased the expansion for BMIs up to 40. That doesn't make it any more effective for somebody at a BMI of 40 versus 36. It's just we're trying to make sure we can have more options to treat patients, because really that's what this is. It's a treatment option. And so it's hard to box people out when something may potentially work, even though it may work better if their BMI was 33 or 32. There can be a certain pattern called concentric collapse on the sleep endoscopy, and patients need to be older than the age of 18. There has been recent FDA approval for the treatment of pediatric Down syndrome with hypoglossal nerve stimulation. And this is really for Down syndrome patients between age 12 and 17. And then finally, the biggest piece is a patient should be intolerant of CPAP and have tried and failed CPAP before we consider an implantable device. The surgery for hypoglossal nerve stimulation, it's outpatient surgery. It's done under general anesthesia. It's about 90 to 120 minutes to complete the surgery. It involves 2 incisions, one under the right neck where we find the hypoglossal nerve. We find the specific branches that help to move the tongue forward, and we put an electrode array around that nerve. There's a wire associated to that gets tunneled down to a pacemaker or an implantable pulse generator that gets housed in the chest. Finally, there's another lead that goes between the ribs that helps to sense breathing. And so collectively, it's 2 incisions where there's 2 implantable pieces. It's honestly a pretty easy recovery. Patients really don't require narcotic pain medications afterwards. I do ask that patients take it easy. I don't want a lot of motion of their arm. I don't want them throwing softballs, golf swings, tennis swings for about a month. That's mainly just to protect the device, not because they can't do it. But with hypoglossal nerve stimulation, it is like I said, it's a journey. From door to door, a lot of times it's a 9-month treatment process to get a patient, adequately treated with HGNS therapy. If you think about it, we have our initial consultation in clinic. A patient then goes and has their sleep study, which is ideally an in-laboratory study, as well as a sleep endoscopy. This process can take 2 to 3 months to get all of this completed. We have to then schedule surgery for the implant if you are deemed a candidate, and that's what we choose collectively between myself as the doctor and you as the patient. We proceed with surgery. It's again the outpatient surgery. We have a 1-week wound check visit, and then at 4 weeks after surgery, we actually turn the device on. So we don't turn it on right away. And even when we first turn it on, we set it very, very low. This allows patients to acclimate to the therapy. We don't want it waking them up at night. So we go low and slow, much like good barbecue. That's what I tell my patients. We start really low on the stimulation, and they will gradually increase the stimulation on their own remote at home. And then once we've hit a point where we're seeing really good tongue protrusion, the patient feels like they're sleeping better, we will order a sleep study to assess the device efficacy. The device itself doesn't actually tell us how well it's treating the sleep apnea. It tells us how many hours a patient uses it, if they're pausing it a lot, because that sort of gets an idea of comfort. And so a lot of common questions I get with this is, well, what happens if it doesn't work? And I think it's important to understand that it doesn't always work as well as we hope. Typically, it helps in some degree, and so we usually don't take the device out. Even if a patient stops using it, we usually leave it in place. It is MRI conditional, meaning patients can have full body MRIs with it. It just generally would be more risk to take it out than to leave it in place. The next common question is, do I feel the stimulation? And the answer is yes. You will certainly feel the stimulation if you turn it on when you're awake. And so what happens when a patient turns therapy on at night, they get an initial impulse in their tongue that says, hey, I turned on, but then it doesn't do anything for a certain amount of time to allow the patient to fall asleep. Most patients do not feel it during the night. It usually does not wake them up. And really, they actually acclimate to the sensation throughout the night. Oftentimes, patients say, oh, it was very strong when it first turned on, but by morning, I have to check to see if it's even running because they've gotten so used to the stimulation. And then finally, it does run on a battery. And so that battery lasts 11 years, much like a cardiac pacemaker, and will need to be changed every 11 years. And so I think one of the most important discussions that I have, and I have it commonly with patients, is that it's really, really intended for patients who struggle with CPAP. You know, a patient, how good of a patient candidate or how good a candidate a patient is for hypoglossal nerve stimulation really hinges on their use of CPAP. And so I like to sort of tell the tale of two patients that are hypothetical. So twin brothers with a diagnosis of severe sleep apnea, their AHI is 31, their BMI is 29, and they meet all the criteria for HGNS. But one brother, he never tolerated CPAP, could never get used to it, ripped it off in the middle of the night. He's an excellent candidate. Now, his brother, who's basically biometrically identical, their sleep apnea is exactly the same. He loves his CPAP. He uses it every night. He's a terrible candidate for hypoglossal nerve stimulation therapy, mainly because he's using his CPAP so well. And unfortunately, it's not always black and white. Some patients can use it a little bit, and it's shades of gray that we have to navigate and really make an informed decision by going over all the risks and benefits. And so to just rehash some final take-home points that I want everybody to understand is that moderate to severe sleep apnea really requires treatment to reduce their risk of disease, cardiometabolic disease. Weight gain and weight is very, very fundamental and important to obstructive sleep apnea, and it's advisable for the majority of patients to try to lose some weight. Finally, CPAP is the gold standard treatment and should be attempted in all patients with moderate to severe sleep apnea. For patients intolerant of CPAP, surgical and non-surgical alternatives should be utilized and considered. And finally, CPAP intolerant patients really require multimodal and multidisciplinary care to ensure adequate treatment. Case in point is that many patients who are intolerant of CPAP have insomnia. Patients with insomnia and sleep apnea, they already have trouble sleeping. You try to put a mask on their face, it's going to be harder to sleep. And so we not only have to address the sleep apnea, but we have to address the insomnia and everything else that goes along with sleep and sleep quality. Because I tell a lot of patients, I can treat the number, I can treat the sleep apnea, but if we don't get you sleeping 6 or 7 hours a night and we don't, help you get to bed at a reasonable time and wake up, you're never going to feel better. So we have to address it holistically. And that brings us to what we've established here at Johns Hopkins, which is our multidisciplinary clinic for CPAP intolerance. And through this program, myself and my colleague, Dr. Lou Pham, have really developed an integrative program leveraging multiple different providers across the healthcare system, from dental, oromaxillofacial surgery, behavioral sleep medicine, obesity medicine, to really help us hit our endpoint, to really help patients find the care they need. And so that concludes the webinar, at least the lecture portion. I am happy to take any and all questions now. Okay, so we have our first question here. If a patient has a very short neck, is he more likely to have obstructive sleep apnea? So what I would say is it's not necessarily the length of the neck. It's really one thing that we do find associated with sleep apnea is neck circumference, or so shirt size. And that's oftentimes a screening questionnaire for patients who are truck drivers or have a CDL or a DOT license, is how big is their neck. And so it's one thing we do correlate with obstructive sleep apnea. And so it's not so much the length of the neck, but really the circumference of the neck or the shirt size is kind of an easy way to think about it. So patients with a size 19 shirt probably have or do have a higher risk of obstructive sleep apnea. So the next question, is there any way to unblock the airway to eventually eliminate the need for a CPAP machine? So yes, and so what I would say is the frame of reference I would come to this is that the airway isn't really blocked. So if a patient's awake and talking, their airway is unobstructed, and so it really comes down to the loss of muscle tone at night. And so there are ways to try to reduce that burden. And so some of it's through surgery to really either eliminate some of the tissue that's collapsing, reduce the size and heaviness of the tissue. And that can eliminate the need for CPAP. Weight loss does that same thing. So it really shrinks or reduces the mechanical load or the weight on the actual airway that's driving the collapse. So the next question, how does one go about strengthening muscle tone in the throat? And so, this would be a wonderful, wonderful treatment. And so there are some investigations that look at myofunctional therapy to try to reduce the strength of the muscles, the tongue. The data on this is pretty limited on what it can do. And those muscles can be as strong as they want, but what happens at night is we lose that neurologic input into the airway. And really, even strengthening the muscles doesn't necessarily mean that they're going to be activated. Even though they can be very strong, they're not activated. And so it's hard to, it's not as fully fleshed out. And so okay, so the next question, my doctor said they're coming fast and they're moving off my screen. So my doctor said it's a risk for glaucoma because it momentarily low blood pressure. I would have to get back to you on the glaucoma risk. I would say that in general, hypoxia, which is low oxygen, is not good for many of the systems in our body. And so if the eye really is dependent on that oxygenation and momentarily low oxygen will worsen glaucoma, then it could definitely be a driver. But unfortunately, I'm not an ophthalmologist, but I could certainly figure that out and ask some of my colleagues and get back to you. Okay, so fifth question. I'm interested in the dental device, worried if Medicare will pay. Any information on the success of getting Medicare to pay? So Medicare will cover oral appliance therapy. Typically with Medicare, a patient is allowed to have one of two treatment options every 5 years. So it can be a CPAP or it can be an oral appliance, depending on certain criteria. Now, they will reimburse for an oral appliance. However, many dentists don't participate with medical insurance. And so unless they're sort of contracted with Medicare, the billing becomes a little bit harder. And sometimes patients are left with an out-of-pocket expense above and beyond what Medicare will cover. And so, typically dentists will advertise if they do participate with Medicare for their oral appliances. The next part of that question was, I have also been told if I lose 35 pounds, I may not need CPAP and that I have difficulty losing weight. Is GLP-1 used as a method for this to improve sleep? So the GLP-1 in itself, the GLP-1 agonist, will not inherently do anything to your sleep as we know. It will facilitate weight loss, and that facilitating weight loss may improve your obstructive sleep apnea. And that's a may, because I've certainly had patients that have lost 90 pounds of weight and still have severe sleep apnea. Now, I've had others that lose 25 pounds and no longer have sleep apnea. And so we don't always know. But if you are overweight or obese, from a medical standpoint, losing weight, whether it's through a GLP-1 or through diet, exercise, or other interventions, is very, very helpful. not only for sleep apnea, but for blood pressure, for cardiovascular risk. One thing to keep in mind with the GLP-1s, with the Ozempics, the Mounjaros, there is a lot of data that suggests when a patient stops or discontinues those medications that they will regain weight. And so that's a little tricky too. And so we always have to be mindful of, did a patient regain weight? Do we need to retest them? Particularly I've had patients that want to do a hypoglossal nerve stimulation device. They come get worked up. They have a sleep study. Their BMI is 31. We do their sleep endoscopy. Hey, they're ready to go. A week before surgery, like, hey, doc, I've lost 30 pounds. I'm like, oh, we should pump the brakes on surgery. We should retest you to make sure you actually still need this surgery. And so the weight is really a moving target that we have to be mindful of in our treatments. Particularly too, I could do a surgery on somebody's soft palate, and if they gain weight, we may have to, I could do surgery on the soft palate. It's very successful. If they gain weight, they may redevelop symptoms and may need additional treatment. Is a night out, so the next question, is a night out test good to diagnose sleep apnea, or is full-blown sleep study better? Okay, so the night out test is a home-based sleep study. It's pretty good. It's validated to diagnose obstructive sleep apnea. Now, it is limited. And so if a patient has a night owl device or a home sleep study that says, yeah, you got sleep apnea, we believe it. It's not going to give us what we call a false positive. It may give us a false negative. These tests are good for screening. So like, let's say somebody comes to see me, they've never been diagnosed with obstructive sleep apnea. They snore, they fall asleep during the day. I say, okay, well, let's do a test. Let's do a home sleep study. Let's order you a night owl or another similar device is something called a watch pat. They're not your conventional sleep apnea testing, but they've been validated. If it, it's a good screening tool. So if it comes back positive, I said, yeah, you definitely got something going on. Let's try you on the CPAP. And so a lot of the insurance companies now mandate home sleep studies as the initial diagnostic test. The full-blown sleep study, if somebody's considering a surgery, in my mind, should be done. We can't always get it because sometimes the insurance companies are tricky to navigate, but usually we can get that done. So a night owl is a completely appropriate test to diagnose sleep apnea. It does not give us a lot of the nuts and bolts that an in-lab sleep study, or doesn't have the granularity of an in-lab sleep study. And so it sort of depends on which situation that we use that test in. I would not operate on somebody based on a night owl sleep test, though. But that would presume they've already tried CPAP and they're CPAP intolerant, and they would be getting some other type of testing, ideally an in-laboratory study. Okay, number 7. I have heard of Inspire used to treat sleep apnea. What is that and how does it work? So Inspire is a hypoglossal nerve stimulation device. So that is that whole last page or a couple slides that I showed. So it's a hypoglossal nerve stimulation device. So it's an implantable system that treats sleep apnea by stimulating the tongue to move forward in the throat to unobstruct the airway. It also coordinates with our breathing. So every time a patient breathes in, the tongue is triggered to stimulate. It's only used at night. A patient controls it with a remote that they turn on before they go to bed. It's a pretty effective, well-tolerated surgery that is becoming more common in the United States. There are other hypoglossal nerve stimulation devices, such as the Genio, that may be making it into the marketplace. Then piggybacking on that question, can a person still get an MRI with Inspire? And the answer is yes. So, sorry, question popped. So can a patient still get an MRI with Inspire? And the answer is yes. The Inspire device, I can't speak to other devices, is at least the newer versions of the Inspire device are MRI conditional, meaning that a patient can get a full body MRI done. Now, MRI compatible and conditional are two different things. So conditional means that certain conditions have to be met to get that MRI. And so there's certain things like the magnet strength in the MRI. So it has to be 1.5 Tesla. It can't be a 3T MRI. Certain coils within the MRI have to be set, and not all facilities have these coils. So if a person does have that implant, it's really important they have their card with them at all times, and that they call ahead and let the MRI facility know, hey, I'm getting an MRI, I have this device. Now, this is similar to patients with sacral nerve stimulators, back stimulators, cardiac pacemakers. Anytime a patient gets magnetic resonance imaging or MRI, which has a really strong magnet, they want to know about metal in the body because it can be a risk. What does nasomaxillary expansion fix? Is my nasal cavity, if my nasal cavity is wide, will that solve it? So nasomaxillary expansion versus nasal breathing. So a lot of patients who have what we call a high arched palate or nasomaxillary sort of narrowing, narrow nasal passage, that kind of doesn't give a lot of support for the tongue, and it can compromise the airway. And so, widening the hard palate in a sort of lateral dimension can improve sleep apnea. It is part of the treatment element. It would fall under that sort of bony surgery group. Fixing the nasal cavity alone, so doing surgery to improve nasal breathing, typically will not improve sleep apnea, mainly because sleep apnea doesn't really happen in the nose. It'll help patients breathe better. They may tolerate CPAP better. They might find sleep more refreshing. But there's been a host of studies that have shown that if you open somebody's nose up through surgery, like a rhinoplasty or a septoplasty, that it doesn't change their apnea-hypopnea index. Okay, so next question. Will head elevation with an adjustable bed help? My home sleep study showed it got me down to under 5. So the answer is, I think you answered your own question there. Yes, it certainly can help. So elevating the head sort of augments gravity in a sense. And so I would put that under the sort of the purview of positional therapy. So head elevation. Now, the degree of elevation may be difficult. And we actually may find, what I find with elevating the head is it's oftentimes keeps a patient, it means they have to sleep on their back because it's really hard to be at 30 degrees and on your side. And we may actually find that being on your side is better than being sort of tilted upright. And so if a patient is 30 degrees upright but can't sleep on their side, they may actually be worse off. And so this really, if we're going to do therapies like that, we have to test to make sure they're effective. And so for you, it sounds like if it got your AHI down to under 5, it's pretty effective. And so I think it's a very viable treatment. Now, what I would argue is that somebody should retest you again in those same conditions in 6 months. Sleep apnea is very variable. And this is kind of some of the dirty that goes into obstructive sleep apnea, is that I could test a patient one night and they might be moderate, and the next night they might be severe. And, it does fluctuate a little bit. So if I did a test on somebody one night and they only slept on their side, they may come back as very mild. And I might say, oh, you don't really have much we need to do. But if the truth is they always sleep on their back and just for some reason they slept on their side, it can skew the results. So my ideal is have multiple nights of data to make sure our treatments are working and that we have a really clear idea of what's happening at night. Okay, so the next question, sometimes I have trouble falling asleep. Is it okay to use sleep aids, Tylenol PM, while using CPAP? Typically, we do not advise the use of sleep aids, such as, over-the-counter sleep aids, such as Tylenol PM, things like that, because they can have side effects. Ambien, Lunesta, these can also be used too, and they're more prescription-based. And they can work, trust me, like they do work. They help people get to sleep. But they can be, addicting, and patients can kind of become dependent on them. And so really, when a patient has insomnia, which it sounds like you're describing, sleep onset insomnia, trouble falling asleep, a lot of times our best therapies are behavioral. And so, reducing any stimulus in the bedroom. So getting rid of TVs, not being on your phone before you go to bed, doing a really good consistent bedtime routine. so that, you were used to falling asleep. And so, not being in front of a screen for an hour before bed, doing something calming before you get into bed, really sort of, working your way into sleep. Things like melatonin are okay to use. Usually we recommend 1 to 3 milligrams, 1 to 3 hours before bedtime. The other thing is, when patients have trouble falling asleep, a lot of times it's because they don't have the pressure or the drive to sleep. And so things like napping during the day really impact our ability to fall asleep at night. And so when a patient has insomnia, we really want to try to consolidate all their sleep to the overnight period. How does one go about strengthening muscle tone in the throat? I think I had gotten to this a little bit earlier, so it will be in the recording, but we really don't have great ways for patients to strengthen the muscles of the throat that are adequate to treat sleep apnea. Myofunctional therapy can try to get to that, but the data on it is very limited in its effect to treat sleep apnea. Okay, so next question. If a patient with sleep apnea is using the CPAP machine consistently, wearing an appliance yet snoring, does that mean the treatment is not effective? Okay, I assume you're talking about your snoring with the CPAP in place. If a patient's still snoring with the CPAP in place, sometimes that means that the therapy is not being as effective as it could. It doesn't mean you're still having sleep apnea, but ideally, realistically, what it tells me is you may need a little bit more pressure. And that's something that would really be discerned off your CPAP data download or compliance report. Typically, patients on CPAP don't need to have repeat sleep studies with the CPAP on because the CPAP itself actually tells the provider how many obstructive breathing events are happening. Okay, 14th question. We are doing good. Diagnosed with moderate sleep apnea several years ago, have gained some weight, have issues with the CPAP machine. How often in this type of position do people get a new sleep study to determine if the sleep apnea has gotten worse? Typically, if we see more than a 10% weight gain, so if somebody's 200 pounds, if they went up to 220, we would want to get a new sleep study. Even if a patient hasn't really gained weight and they're struggling with the CPAP and we're thinking about other alternatives, I generally want an in-laboratory sleep study within the last 18 months, just to make sure things are the same, and haven't changed. What we know is that sleep apnea actually worsens as we age, and for women, sleep apnea worsens as a woman goes through menopause. So if the sleep study was 5 years ago, it may not be reflective even if the weight is the same as it is today. And so getting a new sleep test is, if anybody's considering anything other than CPAP, I recommend that. I always err on the side of having more data to help make decisions and help patients make decisions. Just got the oral appliance and still have choking episodes. Is this normal at first? So oral appliance is much like CPAP, much like hypoglossal nerve stimulation, can titrate. And so if a patient hasn't advanced the jaw far enough on the oral appliance, they can still have events, and that may mean they need to have further advancement. And so I would recommend talking to the doctor who prescribed that to you, or the dentist who's managing it, to say, hey, can I advance this further? I'm still having witnessed apneas or choking events, if it sounds like that's what you're describing. While I dislike CPAP, I am tolerant. I don't doze during the day and don't feel tired, but I yawn a lot. I don't think that's anything particularly concerning to worry about. Sometimes it's a reflex that the body does. As long as your CPAP is reading out and giving you effective treatment, you're not snoring, you're not having gasping, and you're not dozing off, I wouldn't worry too much about it. You sort of fall into that I dislike CPAP, but I'm tolerant. And that's a lot of patients that I see. And, it's kind of the person that it's harder to make decisions regarding using alternatives because, it's kind of like, well, you dislike the CPAP, it's impacting your quality of life. What is your sort of tolerance of doing something else that may not work as well? And so that's really, you're the quality of life patient that uses CPAP but doesn't like it. So a very important distinction in, how we look at all of this. And I think that's our time. I heard that was the last question. I want to thank everybody for joining. I really honor of mine to be able to talk to patients. It's what I live to do. And please, if you would like to make an appointment or be seen or evaluate or have additional questions, please shoot them to us.